Muchas gracias a todos por estar acá. Yo soy la doctora Patricia Madrigal de Clínica Kumara de Costa Rica y realmente es un gran honor siempre poder contar con Kiran Krishnan de MicrobimeLabs, quien nos habla y nos enseña muchísimo siempre sobre la microbiota. El día de hoy él nos va a hablar acerca del Sibo, que es el sobrecrecimiento a nivel de intestino delgado, sobrecrecimiento de bacterias a nivel de intestino delgado. Es que Kiran, bueno, él es microbiólogo, es un experto a nivel internacional en el tema de microbiota, ha participado en múltiples estudios científicos y pues es una persona que también ha participado en el proyecto de microbioma humano. Así que hoy tenemos pues la dicha de tener a alguien que realmente conoce y está en una continua investigación en este tema.
Of course, it's my pleasure. Thank you so much for having me. So first, I'll say hello and then I'll share my slides. I usually turn off my camera while I'm speaking and then we'll come back on and happy to answer questions as well. But this topic is, to me, especially important because I think in general, we think about Sibo in the wrong way. You know, Sibo is classified as a condition of its own. It's a disease state. Certainly in the US it is. And it's often treated with multiple rounds of antibiotics, usually rifaximin, and then, you know, sometimes doctors may put patients on FODMAP diet, but more often than not, you know, they revert and then you have to go back on another round of antibiotics. If a doctor is not, you know, and doesn't have the tendency to prescribe antibiotics, they'll use antimicrobials for a long period of time. Some patients we've met and work with have been on antibiotics like Pau-Diarco, oregano oil, allicin, and so on, non-stop for a couple of years, and they're not doing well, right? The primary symptomology associated with Sibo is the bloating, the distension in the belly, that discomfort, the inability to tolerate lots of different foods. And that becomes, you know, a big quality of life issue. And it becomes, of course, a cosmetic issue as well, because people are embarrassed about having that bloated, you know, 8-month looking pregnant belly all the time. Those are the complaints we tend to get. However, in really investigating Sibo, and I started this maybe about 4 years ago, because we just started getting so many people coming to asking us questions, coming to our clinics in Chicago, complaining of this condition, Sibo, this small intestinal bacterial overgrowth. And so as I started investigating it, and the talk today is kind of a journey through our investigation of Sibo and trying to understand the condition. What the conclusion I came to was that Sibo is not really a condition, right? Sibo is a symptom of a bigger problem. And that bigger problem will actually lead to actual conditions that are much more worse and dangerous than Sibo itself. So that's kind of the journey we're going to take you through. And one of the things we realize as well is that in the course of treatment of Sibo, for the most part, we're not really paying attention to the right things, right? We're not really understanding why there is small intestinal bacterial overgrowth. What are the physiological dysfunctions that are leading to that? And how do you address that? Because clearly addressing the overgrowth using antibiotics or antimicrobials doesn't seem to be the long-term solution. In some cases, it may provide short-term relief, but the patients almost always revert. Right? So that's the journey we're going to go through today. So let me share my screen, and then I would look forward to taking questions after this. Okay, I assume everyone can see this. If for some reason you can't see this or the slides don't advance, please just shout out, and we'll see if we can fix this technical issues. So again, that's why I call this talk Examining the Root Cause of Sibo. And it's all about going beyond the bloat, because certainly in the US, and this may be different in other parts of the world, but certainly in the US, the heavy focus when it comes to Sibo is on this issue of bloating. And both doctors and patients alike, in general, are examining the success of a Sibo treatment based on reducing or eliminating bloating. right? Now, of course, that is a factor within the condition, but does that actually measure success in getting to the root cause of Sibo? So we want to examine this in a little bit more depth and look at the condition more from a root cause focus than from the symptomology associated with it itself. And at the end of the day, is it really a condition, right? So now, when you look at Sibo, it's kind of runs in parallel with IBS-C and D. Now, when you talk to most gastroenterologists or most health practitioners in the US, these are separate conditions. IBS is a separate condition. Sibo is a separate condition. I would argue that they are actually one and the same and just different versions of the same root cause disruption, right? IBS, having irritable bowel, whether it's constipation or diarrhea, is the exact pathophysiology that leads to Sibo-like symptoms. And they both, in fact, are very similar symptomologies or part of a spectrum of symptomologies of some real root cause problems. And when you look at the data, it's almost laughable when you look at the overlaying data between the two. I found prevalence data of between 4 and 78% of irritable bowel syndrome is caused by Sibo, meaning Sibo came first, and then you get irritable bowel syndrome from that. And this number of 4 to 78% to me is just kind of laughable. It means that the data is meaningless, right? But what it does show is likely there's a relationship or even a causative relationship between IBS and Sibo. Most common symptoms of IBS, both C and D, are abdominal pain and or discomfort, irregular stool form and passage, bloating and constipation, hard or lumpy stool, or diarrhea, of course, loose and watery stool in the D version of IBS. Then when you look at the most common symptoms of Sibo, we're talking about abdominal pain or discomfort, bloating, flatulence, loose motion, or constipation, essentially the same, right? The distinctive factor between the two is that somebody went in and did either a hydrogen breath test, which is only about 50% accurate from the data that's available, or they actually went in and sent in a scope to look at the actual measure of the aspirate in the small bowel itself, and that's a much more definitive diagnosis of Sibo itself. And Sibo is defined clinically as a equal or greater than 10 to the 5 colony forming units per ml of upper gut aspirate. So you either have the highly inaccurate hydrogen breath test, which gives false positives, false negatives, or you do the scoped aspirate test, which you're looking then for 10 to the 5 colony forming units or greater growth per ml of the aspirate, then that gives you definitively that it's Sibo or it's a Sibo version of IBS, right? But the whole point here is that even though there is a definitive diagnosis to distinguish Sibo from IBS, ultimately they're all the same root cause, right? So the same thing is going on. It's not like with IBS patients, there's some other pathophysiology occurring in the gut, and with Sibo patients, it's a completely different thing. These conditions are basically one and the same when it comes to the root cause, and they should be treated very similarly, especially if you can identify the root cause. And it's widely accepted that stasis of the bowel, so the lack of the movement of the bowel, is a feature of Sibo. So keep that in mind as well. I think some of the more well-known Sibo researchers and clinicians have talked a lot about stasis. But this 10 to the 5 colony forming units is important because the big question is, if you're below 10 to the 5, then you have normal levels of microbes within your small intestine, normal growth levels. And once you're at 10 to the 5 or above, now you've got a condition that presents with really problematic symptomology, right? So my big question is a couple of fold. What is overgrowing? So if Sibo is small intestinal bacterial overgrowth, what is overgrowing? Are the bacteria that are overgrowing in the small bowel, are they dysbiotic bacteria? Or are they native bacteria to the small bowel? So is it that the native microbes in the small bowel that are normally there, has there been some sort of physiological change that now allows them to grow 1, 2, 3 logs higher than they normally are? Or are these bacteria coming from somewhere else, right? And if they are coming from somewhere else, where are they coming from? What is the source of the overgrowing microbes within the small intestine? And these are basic questions that I've asked myself in looking at Sibo. And I can tell you, when I talk to clinicians who treat Sibo all the time, this was 4 years ago, 3 years ago, when I first started looking into this as a problem, most of them had no answers for these basic questions, right? It's accepted that it's small intestinal bacterial overgrowth, but it's unclear what is overgrowing, if it's native to that region, not native to that region, where is it coming from if it's not native? These are basic questions to me to understand why the condition exists and what is the root cause of the condition. So these were the big questions we asked. And then, you know, why are they overgrowing? Why is it that in certain individuals, a certain threshold level of microbial growth in the small intestine is maintained, and in other individuals, that threshold level can be exceeded? And when you think about it, it's pretty interesting and surprising, because the small intestine is a great place for bacteria to grow in general, right? If you think about just the environment or the physiological structure, it's warm in there, it's moist, lots of food sources coming through. You know, just similar to the large intestine, the structures are somewhat similar. And the large intestine can have upwards of 10 to the 12, 10 to the 13 CFUs per milligram of that case stool, microbes growing, versus in the small intestine, it typically remains in a healthy small intestine 10 to the 4 or less, right? So what is it about the small intestine that is supposed to maintain low microbial growth, despite that area in general being a good place for bacteria to grow? And then if stasis is a really important part of Sibo, what is driving the stasis, right? So why aren't the bowels moving? Why isn't the peristaltic activity working the way it should? Why isn't the migrating mortar complex working the way it should? So why are the bowels slowing down, or maybe even stopped to a certain degree? And then at the end of the day, my biggest question, and I always turn back to a certain degree to evolutionary biology when I look at physiological conditions people are suffering from today, my big question is, did our ancestors have Sibo, right? Was this a problem even 30 years ago, 25 years ago, even 15 years ago? We've noticed, and this is just empirical observation, that in the last 5-6 years, the prevalence rate of this condition has increased quite dramatically, right? 8-9 years ago, we hardly heard about Sibo. We hardly saw people that had the distinct characteristics of Sibo, that bloat, that really severe distension of the belly all the time, especially after eating. So it's interesting. You know, and if our ancestors didn't suffer from this, then what are our natural protections against this kind of overgrowth, right? What is there physiologically that protects the small bowel from exceeding the 10 to the 4, 10 to the 5 CFU limit? So that's the big questions that we have, and we'll try to walk through most of these questions through the presentation. The first thing that I realize is that when you look at Sibo patients, there's no real commonality between them, with the exception maybe that it tends to be more women than men, but that may be slightly more. It's not a clear distinctive factor, but age is not really a thing. You know, history is not really a thing. It can basically pop up in anybody, and with it being so common in society, to me, it must be multifactorial, because it is not tied to any one type of physiology, demographic, history, and so on, right? So there may be multiple factors that culminate together to create this type of symptomology. And then the other part of it is it must be driven by common behaviors, because the condition is becoming more and more prevalent and common. So it can't be some rare origin or some rare dysfunction that leads to this type of condition. It must be driven by something that is relatively common, and there are behaviors or lifestyle choices or exposures that are relatively common, right? So these are the questions, these are the assumptions that we started the whole question with. And so the first two questions, what is overgrowing, and is it dysbiotic or native microbes to the region? And fortunately, there's been a number of studies done on what the culture within a small intestinal bacterial overgrowth looks like. And a lot of that study, and I'll tie this back in later, has been done on liver dysfunction. So non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, and hepatic steatosis. These conditions are all associated with Sibo, right? And so there's been a number of studies in people with these conditions where they've actually taken cultures from the small intestine and then plated them out or done genetic analysis to try to understand what is overgrowing and what does it look like compared to a healthy, normal microbiota in that region. Now, the predominant microbes in a healthy small intestine tend to be gram-positive bacteria like Blauschia and Rumnococcaceae, right? So these are the kinds of organisms that tend to dominate in the small intestine. And again, the gram-positive tends to be the predominant type or class of bacteria. When you get overgrowth in Sibo, overgrowth is characterized by a taxa shift towards more gram-negative bacteria. So that's one critical feature in everything that we're going to talk about as it relates to Sibo and as it relates to the bigger picture of the condition, because this taxa shift is very meaningful, right? And you'll see why it's very meaningful in a few slides. But just keep that in mind, that one of the characteristics of small intestinal bacterial overgrowth is a taxa shift from gram-positive to gram-negative bacteria. So you start to see a lot of Enterobacteriaceae, you start to see a lot of E. coli, Klebsiella pneumoniae, Proteus mirabilis, and then there are other gram-negatives as well, like Pseudomonas. But then there are still some gram-positives, but these are dysfunctional gram-positives. So you find Staphylococcus species in there, Streptococcus species, Enterococcus faecalis, Enterococcus faecium. Enterococcus faecalis and Enterococcus faecium aren't normally found in the small intestine in large amounts, but as it turns out, when you have small intestinal bacterial overgrowth, you tend to find these organisms in the gut more often. So now we know that it's dysbiotic bacteria. It's not the normal healthy microbiota that starts off in the small bowel that for some reason starts to overgrow. It's actually dysbiotic bacteria that is not normal or not native to that ecosystem, at least not at that level, not at that predominant level. So if they are dysbiotic bacteria, then where are they coming from? Right? When I first started looking at the whole Sibo thing, a number of the practitioners I would talk to always said that they believe that Sibo came from bacteria moving up from the cecum into the small intestine, especially into the terminal end of the small intestine, moving up due to a dysfunctional ileocecal valve. Now, that may be part of it. That may be one of the ways that that the dysfunctional microbes get up into the small intestine. But I think that that's actually a secondary route, because I think that would be more of a rare occurrence in the population to support the prevalence and the commonality of this condition. I think there's a much more common source for this type of bacteria. Now, there are also researchers that have shown that some of these Sibo bacteria come in through food poisoning, right? And when you look at the dysbiotic bacteria like E. coli, Klebsiella pneumoniae, staph, or strep being part of the dysfunctional microbiota in Sibo, clearly they could have come in through food poisoning as well. But again, the prevalence of food poisoning or documented cases of food poisoning, at least in the US, actually doesn't compare to that of Sibo. So maybe it's a source, but I think it's a minor source. Same with the minor source of things moving up from the cecum, right? So I think there's, again, a much more common source, because remember, one of the rationales was because of the commonness or the prevalence of this condition, the driver of the condition has to be a relatively common source of behavior. And that to me is the primary source here, and it's the mouth, right? So the mouth, the dysbiosis in the mouth, to me is the biggest driver of Sibo, of small intestinal bacterial overgrowth, and the biggest source so it's not the biggest driver, it's the biggest source of microbes that colonize the small intestine and are allowed to overgrow, right? So the mouth is the source. And there's a couple lines of evidence for this I'll show you in a minute, but one really interesting thing to look at is just the connection between diabetes and certain types of bacteria and Sibo, right? So this is a loose connection. This is through the transitive property, but it starts to give us clues. For example, 60% of diabetic patients yield oral Enterococcus faecalis and Enterococcus faecium, right? As opposed to only 6.6% in control. So when you take diabetics, they have this unique dysfunction in their mouth, in their oral microbiota, right? And they tend to have more Enterococcus faecalis and Enterococcus faecium. Compare that to 6.6% of control, so almost 10 times more. Frequently do they have these two dysfunctional bacteria. A recent study found that Sibo was present in 43% of diabetic patients with chronic diarrhea, and 75% had a significant improvement in the symptoms after being treated with antibiotics, which means that Sibo is highly associated with diabetes. People with diabetes are highly associated with having these dysfunctional microbes within their oral cavity, and they are swallowing those microbes, and then it is also presenting as Sibo. Right. And then, of course, antibiotic treatment improves the symptomology because antibiotic treatment will bring down the growth of some of these organisms. Now, of course, when you follow them out 2, 3, 4 months later, they start to overgrow again. But this is a loose connection. I'm just giving you this as like a teaser that when we first started looking at this, we saw, okay, there were some connections between oral dysfunction, conditions, and Sibo. Now, mind you, there's been a couple of published papers in 2020 that have been more confirmatory, showing that oral dysbiosis has an impact on your gut microbiota, your intestinal microbiota, as far as the colon, and then of course on your overall health as well, because a lot of these bacteria have access to your blood system directly, right, through your gingival tissue and so on. So keep that in mind, that the oral route, the dysbiosis or in the oral microbiota is likely the main source of where these bacteria are coming from and entering into the small intestine, where they're allowed to colonize and they start to overgrow. But then the big question is, why are they overgrowing? When they enter into the small intestine, why do they overgrow, right? What is allowing them to do that? When under normal conditions, it's very hard for bacteria to overgrow in the small intestine. Bacteria in the small intestine are maintained at a healthy 10 to the 4 CFU, typically, despite it physiologically being a good place for bacteria to grow. So we have natural protective mechanisms against overgrowing bacteria in the small intestine, right? There are mechanisms in place to prevent microbes from exceeding a certain threshold level within the small intestine. What are those? Well, number one, it's stomach acid, right? Stomach acid acts as a gastric barrier. So it dramatically reduces the viability of any microbes entering in through the oral cavity, whether it be food or through your saliva from the oral microbiota. And remember, you're swallowing gallons and gallons of saliva every single day, and every milliliter of that saliva is loaded with microbes from your oral microbiota. So you're swallowing constantly lots and lots of oral microbes into your stomach, and then, of course, eventually into your small intestine. But if your stomach acid is functioning the way it should, you've got a healthy physiological pH of 1.3, 1.4, 99.999% of those microbes are going to die in the stomach. You're not going to get any viable organisms into the small intestine. Thereby, they're not able to establish themselves and grow, right? And of course, if food poisoning is a source, if you have adequate stomach acid, the chance of pathogens in food actually making it into the small intestine in viable form in order to colonize and cause illness and take over and overgrow is also quite small. So stomach acid is extremely important. The other part of it is bile secretions and the bile acid pool. Bile is a very strong antimicrobial, especially when bile conjugates with fatty acids from the diet. It becomes a soap. essentially. So bile is a really strong antimicrobial, and combined with dietary fats becomes even stronger as an antimicrobial. And bile is continuously flushed through the system while food is in the system, because the best time for small intestinal bacteria to overgrow is when food is present, because they can metabolize the food and they can increase their numbers relatively quickly. Remember, bacteria grow through logarithmic growth. So that is an opportune time. However, one of our natural ways of combating that is that our bile acid pool continuously recycles through our small intestine while we're digesting food and while food is present in the system, and continuously acts as an antimicrobial wash, among other benefits of bile, which we'll mention in a little bit. But that's a really important part of maintaining lower bacterial count. Now, bile also does a second part. Besides being an antimicrobial by itself with its direct activity, it also, before getting absorbed in the terminal end of the ileum, getting absorbed back through the portal vein into back to the liver, so where it can be recycled, it activates something called the FXR nuclear receptor. The FXR nuclear receptor stimulates the small intestinal epithelium to release antimicrobial compounds into the small intestinal mucosa, right? So the small intestinal epithelium is releasing antimicrobials to prevent overgrowth of bacteria in the small intestine. So this is a very important control mechanism, and bile plays an important role in doing that. Of course, peristalsis, the physical contraction and movement of the bowel to move things along, so food doesn't stay and remain in the small intestine too long, where it can reach a state of putrefaction, where it provides ample opportunity for bacteria to metabolize it and overgrow. That peristalsis, that continuous movement, is one important part of the defense against things sitting there stagnant and getting putrefied and getting fermented. And then the migrating motor complex, once food is gone from the system and it's moved on into the colon, and you've gone through a period of not eating, a normal fasting amount of time, then the migrating motor complex kicks in, which is that electrical sweeping that goes from the stomach all the way down to the large bowel, that sweeps out and kind of cleans the bowel and moves things along, right? So it's extremely important that the migrating motor complex functions. So stomach acid, let's take a look at that for a second. Stomach acid physiology, I'm not going to go into this. Most of you already know this, how stomach acid is formed, but of course it's hydrogen chloride. And it is a magnesium-dependent system. There is the enzymatic component to it to form the HCl, but it is a magnesium-dependent system. And in fact, one of the biggest stimulators in the body, chemical stimulators for stomach acid release, is histamine. Acetylcholine is another one, and gastrin, of course, as well. But as it turns out, histamine is one of the biggest stimulators as well. And although I haven't looked into this, perhaps a lot of use of antihistamines may inhibit some of the signaling, but it's something we need to take a look at, because if you've got a dysfunctional microbiome, you have a significantly increased risk for allergies. And if you've got allergies, you more than likely are on antihistamine of some sort. And would those antihistamines actually interfere with histamine's ability to stimulate the H2 histamine receptor in order to get HCl formed and released? Right, so maybe that in itself has an impact. Bile, of course, as we talked about, you guys know about bile physiologically, but bile is so important. Obviously made in the liver, stored in the gallbladder, released into the duodenum or duodenum, reabsorbed in the ileum, and then sent back to the liver for cleanup and for recycling and reuse. Now, about 95% of bile is reabsorbed, and about 5% is actually converted into secondary bile salts, which is sent into the cecum at that point. And as I mentioned earlier, bile acids, they stimulate the FXR receptor, which stimulates the production of antimicrobial compounds from intestinal epithelial cells. Primary bile acids have been shown to promote the germination of C. diff spores, while secondary bile salts, which is what happens with about 5% of the bile, inhibits the germination of spores into vegetative bacteria. So if you think about that, we've got a natural protection against the overgrowth of opportunistic pathogens like C. diff in our cecum, right? And of course, C. diff is the most common nosocomial infection, and I think it's becoming one of the most common gut infections in general. Is that because we have a overabundance of C. diff in our cecum or in the proximal part of our large intestine because we are compromising our liver and our bile flow, right? If you imagine as the bile acid pool shrinks over time, then there's that 5% of a smaller amount becomes an even smaller amount. So each time we eat, we're sending in less secondary bile salts, which helps control the overgrowth of C. diff. So again, there's a control mechanism there that we may not be paying attention to. And maybe one of the best ways of building resilience and protecting against C. diff infection is to support the liver and make sure we've got adequate bile flow. And then we've got the right microbiota, where a small amount of that microbiota is actually converting bile into secondary bile salts. But that's a bit of a digression. I just want you to keep in mind the physiological importance of bile and what kind of role it may play here. Decreasing levels of bile in the gut favor gram-negative members of the microbiome. So remember that. That is so important when you think about it, right? Remember, one of the key characteristics in a microbiota shift in Sibo is the taxa shift from being gram-positive predominant in the small intestine to gram-negative predominant in the small intestine, right? That's a big problem because gram-negative bacteria also come with LPS, lipopolysaccharide, a potent endotoxin. And I'll show you later on why LPS becomes an even bigger problem in the case of Sibo. And of course, LPS, you guys, if you've heard me talk before, is the big component of metabolic endotoxemia. That is what is leaking through a leaky gut that's causing systemic low-grade inflammation, chronic low-grade inflammation, chronic activation of interleukin-6, chronic activation of TNF, all of these things that are associated with much more poor outcomes long-term. And then even what is very relevant today, it's also one of the most important drivers of significant adverse response to COVID, right? The Boston-Dublin study produced something called the Boston-Dublin score, which is a way of screening and scoring patients to predict who would have the worst outcomes when they're exposed to COVID. What drives your risk for severe response and then hospitalization and even death. And they found really two things. One is elevated interleukin-6, and the second is reduced amount of interleukin-10. Chronically elevated interleukin-6 is a key feature of metabolic endotoxemia, which is the leaking in and translocation of LPS into circulation, a lot of it coming in from the small bowel, and a lot of it due to a taxa shift towards gram-negative bacteria in the small bowel. And that is a function of having reduced amount of bile and bile dysfunctions, right? So there's so many connections here, and hopefully we'll make more of those as we go along. Then the other aspect that protects against overgrowth is peristalsis and the migrating mortar complex, right? So here's an interesting study where they looked at pediatric small intestinal bacterial overgrowth in low-income countries. This is a major issue in impoverished regions. You see kids with that bloated belly. We've all seen those images. So this group was studying what is the driver of pediatric small intestinal bacterial overgrowth in low-income countries, and they find that their hypothesis that the mechanism of Sibo development in the setting of unsanitary living conditions stems from repeated exposure to abnormal levels of lipopolysaccharide via contaminated soil and drinking water, which abrogates the migrating mortar complex, leading to luminal stasis. So this is huge because this tells us a couple of things. Number one, that in this case, Sibo is driven by abnormal bacteria entering in through the oral cavity, right? Because that's where you're getting exposed to these microbes due to the unsanitary conditions. And in this case, they specifically look at lipopolysaccharide being part of that dysbiotic microbiota, so they're gram-negative bacteria, and how that actually drives Sibo because it abrogates the migrating mortar complex, which leads to the stasis in the lumen, right? That's so important. Remember, stasis is a feature of Sibo, right? And then here are some other studies that have shown the same thing. In animal models, E. coli-derived LPS has been shown to decrease both the frequency and strength of small intestinal contractions and to eliminate the migrating motor complex. Remember, E. coli is one of those characteristic organisms that are part of the dysfunctional small intestinal microbiota when you have Sibo, right? So what's happening when you have E. coli and other gram negatives that take over the microbiota in the small intestine, you get more LPS, right? And that increased amount of LPS translocates into the basolateral circulation. And as it turns out, it can dramatically reduce the frequency and strength of the small intestinal contraction and even eliminate the migrating motor complex. This really important physiological capability is eliminated. All of this is associated with or leads to, per these papers, leads to Sibo development, right? And we'll connect all of those dots for you in a bit. Here are some studies that looked at that in much more detail to actually work out the mechanism of action. What they found was that systemic LPS and the induction of TNF-alpha, because when LPS is bound to your innate immune cells, the dendritic cells, when the dendritic cells pick up LPS, it triggers an inflammatory response that leads to the expression of TNF-alpha. And that stops gastric motility, right? And that does it within 60 minutes of injecting LPS into these mice. And it was not possible to elicit gastric motility via potent centrally acting gastrokinetic stimulants. So they showed that the effect of LPS and TNF-alpha acted on the brainstem dorsal vagal complex, causing centralized aberration of motility. So think about that. LPS is leaking in through the small intestinal wall, entering into circulation. And once in circulation, it can make its way to the dorsal vagal complex in the brainstem, where it can trigger an inflammatory response. And there's lots and lots of studies showing LPS being able to trigger inflammatory responses in all parts of the body, including deeper recesses of the brain like the hypothalamus and so on, the amygdala, the hippocampus. It's found in there. It triggers inflammatory response in all of these areas, but it does so in the brainstem as well. And when it turns on a TNF-alpha expression, it causes centralized aberration of motility. Right, so motility is completely compromised when LPS is allowed to circulate in the system. Here's a follow-up study to that, and the same authors, they did in a follow-up study, they induced the inhibition of gastric motility again with systemic administration of LPS, and which stimulated, of course, the endogenous TNF-alpha production. We already know that that's part of the mechanism. An anti-TNF compound was able to restore the central, the thyrotropin releasing hormone, which then activated motility again. Remember in the previous study, they used this prokinetic and they were not able to induce peristalsis and bowel movement, even by introducing this prokinetic, because you had this central abrogation of the nerve signaling from the brain down the brainstem into the gut, into the enteric nervous system. Now, when they applied an anti-TNF compound, they were able to stimulate bowel movement by using this gastrokinetic. So this shows that endogenous TNF-alpha from LPS immune activation likely acts directly within the dorsal vagal complex, leading to central motility aberration, right? So what that means is that it's the inflammatory damage from LPS that is causing the disruption. When they use anti-TNF, then the disruption becomes alleviated, right? So this is really important to note because stasis of the bowel, the dysfunction in migrating motor complex, those are keystone features of Sibo and are likely keystone features of IBS as well. And LPS plays a significant role in driving the stasis behind these conditions. And my big question, when we made this connection, we connected these dots. My big question is, how many doctors are treating LPS endotoxemia in their Sibo patients? This is clearly a driver to me of the one of the foundational problems that lead to Sibo. But when we're dealing with Sibo, we're not dealing and we're not paying attention to LPS endotoxemia, right? The continuous use of just antibiotics and antimicrobials does not address this root cause problem. Now, if endotoxemia is a major issue with Sibo, how common is LPS endotoxemia? Because remember, one of the things I concluded early on was anything that's driving Sibo should also be a relatively common thing, right? And when we did our study back in 2017, which we published, we found that over 50% of healthy normals had severe endotoxemia. This is the amount and increase in serum LPS levels postprandially, right? So this is time 0. This is 5 hours after the meal. So within 5 hours of the meal, they have a 5 to 6x increase in the amount of LPS in circulation. And this is definitively LPS endotoxemia. 55% of the people, the healthy normals that we surveyed and tested out of 100 or so individuals. So it is a very common condition, and it's likely at the root cause of what is driving Sibo within most of the population. Now, here's the other problem. Then when people have Sibo and they have the bloating, the distension, especially in response to carbohydrates, because those are now getting fermented and there's more gas and all that being produced in the small intestine, people tend to increase fat in their diet because they're shifting away from fermentable carbohydrates in their diet to more protein and fat. The problem with that is increased fat actually increases endotoxemia. Fat in the diet is what increases endotoxemia. So in fact, that shift in diet to combat the symptoms of Sibo actually makes the root cause of Sibo worse, right? So something to keep in mind. When you look at, natural protective mechanisms against Sibo, as we mentioned, there's things like stress. There's your stomach acid, but stomach acid gets compromised by things like stress, H. pylori overgrowth, zinc deficiencies, and of course, the use of PPIs and antacids. And if we go back to one of our positions that the biggest source of dysfunctional bacteria in Sibo comes from the oral cavity, then it stands to reason that if we compromise the gastric barrier, if we compromise stomach acid production, more of the cells that are coming in that we're swallowing inevitably from our mouth that goes into our stomach, more of them are entering into our small intestine in a viable state. Right? So that's the presumption. So then any condition where stomach acid is compromised should also be associated with increased risk of Sibo, because now that important gastric barrier is compromised, so the mouth becomes a big source of viable microbes entering into the small intestine. And of course, the mouth is loaded with gram-negative bacteria like Enterococcus, E. coli, Klebsiella, and so on. And so sure enough, when you look at the use of things like PPIs, proton pump inhibitors. Proton pump inhibitors' job solely is to reduce the amount of HCl being produced in the stomach. So it elevates the pH in the stomach. Several meta-analysis and systemic reviews have reported that patients treated with PPIs, as well as post-gastrectomy patients, have a higher frequency of small intestinal bacterial overgrowth compared to patients who lack the aforementioned conditions. And in fact, they concluded at this time, PPI-induced dysbiosis is considered a type of Sibo. So it starts to become more clear that compromising stomach acid and any sort of compromise in the production of stomach acid is a major root cause of Sibo. And again, I've not met a single clinician when I first started doing this that is treating and understanding what's going on with stomach acid in their Sibo patients. Right? It's over and over again, the use of antibiotics and use of antimicrobials. And yet it's quite clear when stomach acid production is compromised, whether it's through the use of PPIs, or I'll show you in the next slide, other reasons, Sibo becomes a significant risk. Now, the other way that you can actually induce stomach acid dysfunction is through H. pylori infection. I'll show you that in a second. But here's another study that shows increased incidence of small intestinal bacterial overgrowth during proton pump inhibitor therapy. Sibo was detected in 50% of patients using PPIs, 24.5% of patients with IBS, and 6% of healthy controls, right? So something like 9 times more in patients using PPIs than in healthy controls. So there's definitely a very strong correlation here. And so PPI use, compromising stomach acid, is a big driver and risk and root cause of Sibo. Now, we were talking about how bile is highly protective as well, bile acting as an strong antimicrobial, so preventing the growth of bacteria, especially when food is present in the small intestine. And so anytime you've got, and then of course, bile also triggers the FXR nuclear receptor, which causes the small intestinal epithelium to release antimicrobials, thereby adding in another layer of antimicrobial functionality to reduce the overgrowth of bacteria or maintain a low level of growth of bacteria in the small intestine. So that stands to reason that if bile is so important, then if the liver is compromised, then Sibo is a significant risk, right? And so sure enough, people with liver disease have a much higher incidence rate of Sibo, right? So this shows this paper entitled Liver Disease Symptoms in Non-Alcoholic Fatty Liver Disease, Liver Disease Symptoms in Non-Alcoholic Fatty Liver Disease and Small Intestinal Bacterial Overgrowth. They conclude that some studies reinforce the concept that small intestinal bacterial overgrowth plays an important role in the pathogenesis of non-alcoholic fatty liver disease through endotoxin of bacteria and tumor necrosis factor as effective mediators. So here's TNF again, here's endotoxin, in this case LPS. Now here's what's really interesting about this particular paper, right? I've talked about how liver dysfunction and thereby dysfunction in the bile acid pool, so reducing amounts of bile acid pool, reducing the deconjugation of bile and so on, will lead to small intestinal bacterial overgrowth because bile is a very important part of maintaining low levels of bacteria. This paper shows then the second part of that cycle where more small intestinal bacterial overgrowth, which remember is associated with a taxar shift, right, in the small intestine, which means more endotoxins, which means more leaky gut, more toxins leaking into circulation. Anywhere that the toxin ends up triggers TNF alpha mediated immune response, right? So now they're showing the other end of the cycle where as Sibo gets worse, it actually drives more liver dysfunction, more non-alcoholic fatty liver disease. And as liver disease progresses, bile is further compromised, overgrowth continues to increase, which then further compromises the liver. So this is the vicious cycle. They're one in the same. To me, people with Sibo are likely at some form of early stage of non-alcoholic fatty liver disease, right? Their Sibo is a symptom that's indicating a root cause dysfunction that's going to lead to liver cirrhosis. It's going to lead to non-alcoholic steatohepatitis and then full-on, liver dysfunction, end-stage liver disease, right? That is the progression. So we are concerned about the bloat, and we're trying to bring down the growth of bacteria in the small intestine, but we're not addressing the root cause because the root cause will lead to much more scarier conditions because that endotoxemia, that leakiness in the gut that also stops the bowel, right, because of LPS getting into the dorsal vagal complex, that endotoxemia is also the #1 driver of Alzheimer's, right? Studies published in 2017, 2018 showed that LPS from the gut microbiota gets into the perinuclear region in the Alzheimer's brain and gets enriched, triggers TNF alpha-based inflammation, which starts the process of neurodegeneration. That LPS that's in the dorsal vagal complex also gets into the central nervous system and starts the neurodegeneration that's characteristic in Parkinson's. That LPS also gets into the J&K region of the hypothalamus and creates central insulin resistance, right? That LPS will also target and cause harm to the islet cells in the pancreas, thereby setting you up for type 2 diabetes. right? It does everything. The LPS in circulation is at the root cause of the vast majority of chronic illnesses that we face today. And it is a dramatic feature of Sibo, right? So when you have patients, I don't have patients, fortunately, because I'm a researcher. I'm not brave enough to deal with patients. But when you have patients with Sibo, it's not a bloating issue, even though that's the symptom that they're concerned about. That's not the focus. The focus is there's something severely wrong with the gut that leads to these symptoms. But the dysfunction in the gut that's leading to the symptoms will also be the key components that lead to much more serious conditions down the road, like liver failure, right? Alzheimer's, autoimmune conditions, diabetes, and so on. Right, so that's the connection I'm trying to make here, because at least in the US, and I don't know if this is the case in Central, South America, and in Europe as well, but at least in the US, the big focus in treating Sibo is continuously trying to hit the overgrowth with antimicrobials to bring down the bloat. Because what we're looking at in terms of success of treating Sibo is, can we reduce the bloat? Right, so let's move on. They also found, here's another study that shows small intestinal bacterial overgrowth is associated with non-alcoholic fatty liver disease, like now you're experts on already. Non-alcoholic fatty liver disease occurred in 45.4% of the study group. The study group are people with positive for Sibo, compared to just 17% of people in the control group that are not positive for Sibo. And then, of course, their liver enzymes are off as well. Their increased risk for type 2 diabetes and hypertension all go together, right? Remember, because this is all being driven by endotoxemia, by leakiness in the gut, by stasis in the bowel not moving, and by having compromised stomach acid as well, right? So those are all things that are driving Sibo. Now, peristalsis in the migrating mortar complex, gastroparesis, I'm not sure where the slides went, but there are slides also showing that H. pylori infection, which compromises stomach acid, is also associated with Sibo, right? So that's another component. H. pylori infection, when H. pylori grows above 10 to the 6 CFUs per aspirate of the gastric compartment, then you've got compromised stomach acid production, which increases the pH in the stomach, and that condition is also associated with Sibo. So PPI use in the stomach and H. pylori infection. And then in the small bowel, it's compromised bile function, bile production, bile acid pool, bile recycling, bile conjugation and deconjugation, and compromised liver, and then eventually compromised movement of the bowel, peristalsis, and the migrating mortar complex, right? So all of these conditions all work together to create a significant issue for Sibo. This slide is a little bit off of in order, but that is the big picture here, right? So when we're thinking about treating Sibo, in our view, the most important things to pay attention to are liver function, gastric function, and then leakiness in the gut. Right, so we got to get the bowels moving. We got to get the bowels sealed up. We got to stop that endotoxemia. We got to support the liver, and we got to improve gastric emptying. We got to we in most cases we also have to target and be concerned about H. pylori. And certainly if they're on PPIs, they have to somehow come off those PPIs, right? That's a big issue. And when we look at most clinicians in the US, none of these things are being paid attention to in Sibo patients, right? So here's how we look at the treatment. You may want to do an antimicrobial antibiotic early on with Sibo, right? Just to bring down the levels that are present at the moment. But that's not going to be the only treatment, because when you do that, you're going to cause further dysbiosis, even though you might bring down the overgrowth in the small intestine temporarily, you will also cause other dysbiosis. So while you're doing that, while you are using antibiotics and antimicrobials, it becomes incredibly important to address the underlying issue of stasis, which involves LPS endotoxemia. Right, so that is something to keep in mind. Prokinetics won't work. Like that study showed that as long as LPS endotoxemia is present and causing inflammation in the dorsal vagal complex, and there's that TNF activation. You can use prokinetics, but it's not going to do the job. You need to reduce the inflammation in the dorsal vagal complex before prokinetics can actually get the bowels moving again. So again, endotoxemia has to be addressed. Low HCl and gastroparesis also need to be addressed. Those are fundamental issues. Liver support is absolutely critical, and to reduce the risk of comorbidities, mucosal damage, because there's no doubt that when you have a taxa shift to gram-negative bacteria in the small intestine, you've got all of this inflammation in the small intestine because of bacterial overgrowth, because of the increased presence of LPS, because of the translocation of LPS. You absolutely have mucosal damage and mucosal inflammation in these patients, right? So it becomes really important to help repair that physiology as well. And then the colonic saccharolytic bacteria, these are the really important bacteria that produce short chain fatty acids like butyrate, propionate, and acetate. They need support because people who have Sibo have basically eliminated fermentable carbohydrates from the diet. So these saccharolytic bacteria that are sitting in the large bowel waiting for non-digested starches and fermentive carbohydrates to enter into the system. So now you're reducing the levels of some of these keystone species in the large intestine, like Fecalum bacteria prosnitzi, Bifidobacterium, Bifidobacterium longum, Akkermansia. These organisms now need further support because it's part of their job to maintain the microbiota. So here's our recommended solution. When we looked at our offerings, we knew that we could manage the endotoxemia very well. That's the whole purpose of our flagship probiotic, Megaspore Biotic, right? Megaspore Biotic in a 2017 study was published showing that it reduced significantly, over 60% metabolic endotoxemia within 30 days of taking it. Right, and that was published in the World Journal of Gastrointestinal Pathophysiology. We've got a second version of that study that started last year. Of course, COVID has slowed it down, but it's moving along, progressing quite nicely right now. But we've shown the same kind of mechanism in a couple other studies with the Megaspore Biotic already. So we know we can address the endotoxemia, which is critical, but we weren't addressing some of the other issues. We weren't addressing the H. pylori overgrowth. We were not addressing the gastroparesis. We were not addressing the dysfunction in bile production and secretion as well. So we created this product called MegaGuard. And I can tell you for so many people, this has become one of the most important critical products that they take before eating, because what it does is it has this prescription grade artichoke leaf extract that's actually sold as a prescription in Germany and a couple other countries in the EU, but it stimulates bile production and it balances cholesterol levels. So this becomes really important to ensuring proper bile acid pool accumulation and secretion as well. It's also got this licorice flavonoid that protects the gastric mucosa against H. pylori. It brings down the level of H. pylori, but not so low that H. pylori is eliminated, which is what antibiotics would do. So this controls H. pylori because my guess is at least 50% of Sibo people have elevated H. pylori, because about 50% of the general population does. The gingerroot extract is also really important because it accelerates gastric emptying, it soothes nausea, and it can help with soothing the bowel movements themselves, right? So these can act to a certain degree as a prokinetic, to working against a gastroparesis, working against H. pylori associated reduction in HCl production, and then of course supports bile acid production as well. Now, in combination of that, you need the Megaspore, because the Megaspore addresses the endotoxemia and then the overgrowth of the gram-negative bacteria, because the spores, which are gram-positive spores, actually competitively exclude gram-negative bacteria within the system, or at least opportunistic gram-negative bacteria. So it'll help bring down some of that overgrowth of gram-negative bacteria. And megamucosa is critical because megamucosa is designed to fix and help the mucosal layer, right? So it provides the kind of support that your microbiota and your intestinal epithelium needs in order to rebuild and reproduce things like the mucin layer that makes up the mucosa, to increase the growth of Akkermansia, which plays a really important role in stimulating the production of mucus so that you can rebuild the mucosa, and also brings down inflammatory response, especially TNF alpha response in the mucosa itself. And then, of course, you need a prebiotic, because remember, the colonic saccharolytic bacteria have been suffering in people with Sibo because they're not eating fermentable carbohydrates. They're not eating resistant starches. They're not eating foods that have FODMAPs in it. Those are all the kinds of foods that the colonic keystone species need. So the prebiotic really helps feed those really critically important keystone strains in the large intestine, right? So you need all of these types of things, and then anything else you would do for liver support, right? So things like milk distill, and you might use other compounds for liver support, because liver support also has to be addressed. But this combination here addresses some of the root cause issues that drive Sibo. But keep in mind that Sibo is merely a symptom of a significant dysfunction going on in the bowel, a compromised production of stomach acid, a slowing down, a complete stopping of the bowel, the compromised peristalsis and migrating motor complex, a compromised liver, a severely leaky gut, disrupted mucosa, a taxa shift, a gram-negative bacteria. And all of these things not only is creating a Sibo-like symptom right now, but these are all the same exact things that are at the root cause of the vast majority of chronic illnesses. That's why it becomes so important when you see Sibo-like conditions, not thinking of Sibo as a standalone condition of its own to be addressed by trying to bring down the small intestinal bacterial overgrowth, typically with antibiotics or antimicrobials. Sibo is a symptom of a huge dysfunction going on in the bowel. So that is the overall picture, and this is a special that I think that's been worked out with your host. It's a 10% off your entire shopping cart. I believe there is a code here somewhere. Raphael, you might know what the code would be in order to enact this discount?
Yes, we will follow up with the details after this webinar.
Okay, great. So we'll get a special code for all of the people that attended the webinar. You'll get a special code so you can actually activate this this discount. Now, keep in mind the product we're talking about is MegaGuard, and then it goes along with the Megaspore and the Mega Mucosa, and then the Mega Pre as well. These are going to be important things for Sibo individuals because they need a lot of repair and recovery on the intestinal lining. And of course, MegaGuard becomes a really potent companion for people that have experienced IBS or Sibo constantly. They should take it about 15 minutes or so before they eat, and they'll start to find a very dramatic difference in how their body responds or how their gut responds to food. So I am happy to take questions.
Okay, perfect. Thank you, Kiran. So we have some questions.
Yeah.
So how long stay on MegaGuard after treating Sibo?
Great question. So I think if the individual's Sibo symptoms, Sibo-related symptoms are well under control, meaning they can eat most things, not generate a bloat, not generate distension and all kinds of dysfunction in the gut, you could probably cease the use of MegaGuard. But as long as they are responding that way to large categories of food, meaning vegetables in general or fruits and carbohydrates in general, then they should continue utilizing MegaGuard.
And also changes in the protocol if you suspect Sibo?
Yes. So Sibo and Sifo to me have the same underlying pathophysiology, right? It really is determined by what is your biggest source of dysbiosis. If you had opportunistic overgrowth of, say, Candida or other fungal organisms in your small bowel to begin with, and that may be diet driven, or it may be driven by the fact that you've used a lot of antibiotics in the past, then that, when your bowels stop and bile stops circulating and stomach acid's compromised, When all of those things happen, then it allows for fungal overgrowth to occur. So I think you still have to address the same issues, the leakiness in the gut, compromised liver, compromised stomach acid. All of those things have to still be addressed, whether it's SIFO or Sibo. And then fortunately, when the small intestinal microbes start to come back, they will competitively exclude these organisms. In the case of SIFO, you may need to go to an antifungal for a small period of time, but always doing anti-anything like antifungal, antibacterial, always doing it with in parallel with healing as well, right? Because if you're using those things by themselves, they are also causing damage to the system. Right? They're causing damage to the lining, they're causing damage to the ecosystem, and although they may be required sometimes to get control of overgrowths and things that are going on, you want to do it in parallel with using the right probiotic like the megaspore and so on.
And what about add to this treatment megacidin?
Megacidin, yes. So we launched megacidin in November, and megacidin becomes a really important component because it deals with dysbiosis in the oral cavity, right? So most people with Sibo likely have a dysbiotic oral cavity as well, likely high abundance of gram-negative bacteria like E. coli and Enterococcus, or maybe even dysbiotic or opportunistic gram-positive bacteria like strep and staph. Those tend to be great areas to harbor these kind of organisms and opportunists, and the megacidin actually brings those under control as well. We definitely need oral microbiota control and treatment when it comes to bowel dysfunctions, right? The studies are coming out. It's going to become very clear in the next 12 to 18 months that a major source of dysbiosis in the gut comes from the mouth.
Okay, yes. And also, does systematic alkalinization of water can predispose to Sibo, or worse, the symptomatology?
You know, it's quite possible. I mean, I think if you have alkaline water and you're drinking alkaline water, it could buffer the pH in the stomach. And if it buffers the pH in the stomach, it's going to increase the pH in the stomach, which allows for more microbes either through food or your own saliva to survive through. So I think that could be a problem. One thing that's important to note is that this whole system from the mouth downwards requires more acidic pH than anything else, right? Until you get to the large bowel and the pH goes anywhere from around 6 to close to neutral around 7. But most of the small bowel and of course the oral and gastric areas are all very acidic, as they should be. So anytime you throw in an alkaline liquid in there, it's going to buffer it and disrupt the acidity.
Okay. And what about dietary interventions or antimicrobials?
Yeah, so maybe antimicrobials, yeah. You know,
Yes.
and yeah, if your patient requires a dramatic change in the diet to reduce symptoms associated with bloating, in my view, that's fine if you're doing it temporarily. What tends to happen is this becomes the people's diet, right? That they can't eat carbohydrates, they can't eat fermentable carbohydrates, they can't eat fiber because they bloat. And when they stop eating it, they don't have the bloat, so they just never eat it again. And in fact, they become quite anxious against it. I think if you do it for a short period of time to bring the bloating symptoms under control, as you're trying to repair the gut, support the liver, bring stomach acid production back, seal the leakiness in the gut, if you're doing it temporarily, I think that's fine, especially if you're using things like the prebiotic, which is providing oligosaccharides to the large intestinal bacteria. So you can do that dietary intervention, but I would say for a short amount of time, no more than 10 weeks, 8 weeks preferably. But you have to be using the probiotic, the prebiotic, megamucosa during that time.
Okay. And can you explain how to use megacidin before meals? How many times a day? How long as treatment?
Sure, yeah. So the megacidin is a spray bottle, and you can do upwards of 4 to 6 sprays at any given time. You just spray it into the mouth. I usually spray it in a few different directions, so I get it nicely coated in most of the gingival tissue, most of the buccal immune tissue in there as well. And you can use it 3-4 times a day. I typically use it right after brushing in the morning. So I brush my teeth, I spray that in, and then before I ever eat or drink anything, I allow that to sit in my oral cavity for the morning period. And then I use it again, usually within about 15 or 20 minutes of eating. And I only eat a couple times a day because I'm typically fasting in the morning. So I use it right before eating. So typically you can use it 3 times a day in the morning and before 2 of your each largest meals. You can also use it if you want to not do it before dinner, you can actually do it after you've brushed your teeth and all that at night, and you do it right before sleeping. Because then it allows it to sit in your mouth for a longer period of time before you eventually swallow it. So morning, evening, and you could do an optional midday spray as well before lunch.
Okay. And suggestions for treating hydrogen sulfide? What changes in the protocol?
For dealing with hydrogen sulfide?
Yes.
For dealing with hydrogen sulfide, what you'll have to do is temporarily reduce the intake of high sulfate foods, right? So that sulfate is being converted to hydrogen sulfide. So that's one of the things. So when you Google high sulfate foods, you'll find things like mushrooms, certain types of seafood, Brussels sprouts. These kinds of things tend to be high in sulfates. So you want to reduce high sulfate foods for a short amount of time. I'd say 4 to 6 week period. I would also reduce fat intake because one of the biggest drivers of hydrogen sulfide production is an organism called Bilophila wadsworthia. And Bilophila wadsworthia actually grows when you have more bile in the system and if you're dysbiotic. So it's an opportunistic bacteria, right? So if other bacteria have been harmed, it'll start to take over because it is quite resistant to bile. In fact, it loves bile. Hence, it's called Bilophila. So if you're eating if your patient is eating lots of fat because they couldn't eat the carbohydrates, they get bloat and so on, then they're seeing an overgrowth of Bilophila. That's one of the organisms that actually creates the hydrogen sulfide. So you'd probably want to reduce the fat in the diet. You want to reduce sulfate-rich foods, and you want to move more towards non-sulfate rich foods, a little bit more plant-based material. You could bump up protein a little bit as well.
And what about aged people? The protocol is the same, the treatment?
What kind of people, sorry?
Aged people, old people.
Oh, old people. Yes, absolutely the same. In fact, for older people, you probably want to do even more concentrated liver support because over time, your liver inevitably becomes dysfunctional, and then you likely want to use digestive enzymes quite a bit as well because pancreatic insufficiency is a major issue once you hit over 50. Right? So you're probably not producing enough of your own pancreatic enzymes to even properly digest the food in the small intestine. So you're not getting adequate absorption of the food and breakdown of the food in the small intestine. That in itself can lead to compromise and putrefaction in the terminal ends of the small intestine if the food isn't broken down adequately. So with older people, I would use more liver support and then maybe add a digestive enzyme in there as well.
And what about hydrogen dominant versus methane dominant? Any difference in the treatment?
Yeah, it's so interesting to me that that had become a thing where people were trying to distinguish between hydrogen and methane dominant. The only reason why you would have one or the other is just which class of microbes ended up overgrowing, right? But the reason for the overgrowth is the same in both of those conditions, right? So it's the same issues as one or the other. So to me, it shouldn't matter. You should be still paying attention to the same things, the same gut, the same stomach support, the gastric support, liver support, and then prokinetics once you've started to heal the lining of the gut and the leakiness in the gut. I don't think it's different. I think you would treat them both the same way.
Okay. If you use MegaGuard in the long run, can it change the stomach pH negatively? It is necessary
It cannot, no.
No, okay.
No. There's nothing in it that has a negative impact on stomach acid. Remember, the licorice flavonoid controls H. pylori. So it brings down H. pylori, but it doesn't eliminate it, which is important because eliminated H. pylori increases risk for certain populations, right? So you need some degree of H. pylori because, as studies have shown, H. pylori, can protect you from certain types of cancers and issues within the bowel. But if it's overgrown, then you've got inflammation in the gastric system. You've got risk for ulcers. You've got increased risk for Alzheimer's and other things. So you need H. pylori in this really healthy range, and it seems to maintain H. pylori in that healthy range. Outside of that, there's no other negative impact on pH.
And do you think sometimes it's necessary or is better to start with Restore Flora instead or Megaspore?
Yeah, that's a great question. I'm glad you brought that up, because I would say that if it's CFO, your patient might actually do better with Restore Flora in the beginning, or if the patient is also accompanied by upper respiratory issues, if they have chronic upper respiratory issues, the clausi, the high concentration of clausi in the Restore Flora helps with upper respiratory tract issues. But with the presence of Saccharomyces boulardii, the Saccharomyces boulardii actually helps a lot with overgrowth of fungal organisms. So that's a good question. I think if CFO, it might be worth trying Restore Flora first before perhaps even adding in the Megaspore.
Okay, so perfect. So we don't have more questions. So thank you a lot. We learned a lot. So I learned a lot, and thank you very much.
It's my pleasure. Thank you so much for having me, and thank you for everyone that joined us. I see we had a pretty nice crowd here, so thank you for spending your Saturday with us. Those of you who are in Spain, thank you for spending your Saturday evening with us, because I know there's lots of fun things you can do in Spain, although maybe not now because of COVID. But I really appreciate the opportunity, Patricia. Thank you.
Okay. Thank you, Kiran.
Yeah.